Good morning, ladies and gentlemen. I am Dr. Phil Schauer, and on behalf of co-directors Adrian Park from Anne Arundel Medical Center in Maryland and Steve Wexner, Cleveland Clinic, Florida, I would like to welcome you to Innovations in Surgery. We do have an exciting program in store for you this morning, and we're glad you could make it today. So without further ado, I'm going to introduce the program, or turn the program over to our moderator, my colleague, Dr. Stacy Brethauer, who will announce today's program. Stacy?
Great, thanks, Phil. We have a great program today. We're going to have a debate, and the title is BMI less than 35, how low can you go? So we're going to start with a 10-minute pro on the topic, followed by a 10-minute con discussion by Dr. Needleman at OSU, with 5-minute rebuttals on each part, and then we'll open the floor up for discussion, and hopefully we'll have some interesting debate about the BMI as a criteria for bariatric and metabolic surgery. So I'll turn the floor over to Phil for his presentation.
Good. Thank you, Stacy. And in just a moment after I give the pro argument, Dr. Brad Needleman at Ohio State will give a counter argument. And great. Now, this subject we actually addressed at this conference a couple years ago, and I'll just give you the upshot of that. After a consensus vote among all the sites available, the consensus was that bariatric surgery below 35 was not supported by the literature for any reason. So we've come a long way in the past 2 years, and I'm going to give you an argument that will suggest, based on the evidence, that for certain circumstances, there's definitely strong evidence to support surgery for a body mass index less than 35. Now, there may not be a lot of health insurance providers that will cover it below 35, but I'm telling you this morning that I think that for surgeons out there in the community, it is appropriate, and I would certainly support you in any legal issue that came up regarding an indication for surgery below a BMI of 35. These are the standard disclosures. There are no particular conflicts of interest with regard to this particular presentation. I will mention, though, one of the studies we'll be talking about, the Stampede trial, was supported by Ethicon Endosurgery. Okay, let me begin by just sharing with you a recent review. This was actually conducted by one of our fellows, and Tom Rogala, published in the Journal of Obesity just last year. This was a systematic review of observational studies published regarding bariatric surgery in a BMI of 35. There were a total of 18 studies published from all around the world with a variety of different operations, including the conventional procedures like gastric bypass, gastric banding, sleeve gastrectomy, but also some innovative operations like the duodenal vaginal bypass, ileal transposition, and others. Most of these studies were fairly small. The average ends were in the neighborhood of 10, 15, 30, or up to 60 patients, relatively small studies. The body mass index of these studies range anywhere from a BMI as low as 25 up to about 35. And the mean follow-up in most of these studies was fairly short, averaging about 1 to 2 years. However, all these studies were quite consistent with their report on the efficacy. And this slide shows you that typically body mass index pre-surgery average of 30 decreased to about 24 following the procedure. Fasting plasma glucose above 200 decreased to 112, and the average A1C of 9% decreased down to 6.3% following surgery. So fairly consistent data, 18 studies across many different centers in many different parts of the world. Now, what's relatively new are some randomized controlled trials that support surgery for BMI less than 35, particularly in patients with type 2 diabetes. Now, the first was actually published in 2008 by John Dixon. I know this publication is quite familiar to this audience, so I'll quickly summarize it. Small study, 60 patients, gastric banding compared to medical therapy for type 2 diabetes. Most of these folks had early diabetes. Average insulin, or average A1C was 7.7%. They had diabetes less than 2 years. The BMI range was 30 to 40. Now, I will point out that it is true most of these patients, a majority, had a BMI greater than 35, but a significant percentage did have a BMI below 35. And what they found at 2 years was that surgery was by far superior, achieving a 73% remission rate compared to only 13% with intensive medical therapy. Obviously, weight loss was a big driver of this overall benefit. They also did find that the body mass index itself was not a predictor of overall remission. Now, next is a study conducted here at the Cleveland Clinic, the Stampede trial. This was a multidisciplinary effort among surgeons, endocrinologists, and cardiologists here at the Cleveland Clinic. And this study compared gastric bypass, sleeve gastrectomy, and intensive medical therapy for treating patients with type 2 diabetes. This shows you the baseline characteristics. Take-home message here is that these patients in general had fairly advanced diabetes with average duration more than 8 years. Average A1C was in the high 8 to low 9% range, and most of these patients were on lots of medications for their diabetes, blood pressure, and lipids prior to even starting the study. This shows you the primary and secondary efficacy endpoints. In terms of the primary goal of achieving hemoglobin A1C less than 6%, surgery was by far superior, both gastric bypass and sleeve gastrectomy, compared to medical therapy. And when you look at the probability of reaching that goal without medications, all of the folks that had gastric bypass, 42%, who met that criteria, did so without requiring medications. This was true to a lesser extent with sleeve gastrectomy, and of course none of the patients in the medical group achieved that goal without medical therapy. There are also big differences in fasting plasma glucose, body mass index, changes in HDL, cholesterol, triglycerides, and an important marker of cardiovascular risk, C-reactive protein. In this study, we did not see a difference in blood pressure or total cholesterol between the three groups. This is primarily because these are fairly well managed with antihypertensives and statins prior to the study starting. And real briefly, this shows you the time course and the very rapid drop in hemoglobin A1C favoring surgery compared to medical therapy. This shows you similarly the change in body mass index, a very large treatment effect with surgery compared to medical therapy. And this shows you that while achieving superior glycemic control, the surgical group was able to be weaned from most of their anti-diabetic medications, and most of these patients, almost all of them in fact, were weaned off their insulin at the 12-month time period. Important to recognize adverse events. There are really no major surprises here. There were 4 reoperations. One was for bleeding. There was 1 sleeve leak. 1 patient had abdominal pain of unknown etiology and required diagnostic laparoscopy, which was negative. 1 patient developed gallstones. Other than that, there are really no other major differences between the medical therapy and the surgical group. So the Stampede study showed that surgery was superior to medical therapy in terms of glycemic control and also improved important cardiovascular risk factors, while at the same time reduced dependency on medical therapy. And now I want to briefly show you the Mingroni-Rubino study. Now this study was published in the same issue of the New England Journal of Medicine. It did involve patients with severe obesity, BMI greater than 35. I'm showing you this study because they found that in this study, the body mass index, which ranged as high as the high 40s, was really not a predictor of overall remission rates in the surgical groups. And this, again, is an important point when considering patients with BMI less than 35, because it points out that that arbitrary threshold of 35 really is arbitrary. This study, again, had a similar patient population. A1C was average 8.5%, and the average duration of diabetes about 6 years. And what they found was that both operations, gastric bypass and the BPD procedure, had a superior remission rate compared to conventional medical therapy in this group of patients with BMI above 35. They also showed benefits in terms of fasting glucose, blood pressure, total cholesterol, and so forth, favoring the various procedures overall. I would recommend that you read the editorial on that issue of New England Journal of Medicine, and basically these two world-renowned endocrinologists seem to strongly support the notion that surgery should be included as a therapy in some patients for diabetes. Now, when you combine those three studies, you have 3 randomized controlled trials that are quite consistent. 2 of them include patients with BMI less than 35. So we're achieving quite consistencies with these level 1 studies. I want to call your attention to a study published just 2 days ago in JAMA. Some of you may be familiar with this study. Dr. Stacy A, one of my former fellows, I'm very proud to say, was the first author of this study, as well as the group originally at Columbia, headed by Barry Anabnett. Hopefully Barry is on this call. Maybe he can comment on this particular study. This was a randomized trial comparing gastric bypass with very intensive medical therapy. It involved 4 hospitals, including 1 site in Taiwan. The N was 120. These patients all had fairly advanced type 2 diabetes with a BMI range between 30 and 40. Now, this study had a majority of the patients with a BMI less than 35. So a majority of these 120 patients had a BMI less than 35. And their endpoint was the rate of patients reaching all 3 ADA composite goal endpoints. A1C less than 7%, LDL less than 100, systolic blood pressure less than 130. And this is their primary endpoint data, showing here that the gastric bypass group reached that endpoint 49% of the time, while the lifestyle and medical management group reached that only 19%. And this value was highly statistically significant with an odds ratio of 4.8. And you can see the individual components here. It was mainly driven by reduction in A1C. Here you see a huge odds ratio of 6.0. There was not such an effect with cholesterol or systolic blood pressure. So the majority of the effect was really the improvement in glycemic control. And here you see the rate of reaching A1C of less than 6% was quite similar to the Stampede study, 44% versus 9%. In Stampede, it was 42 versus 12%. So almost identical in that regard. In fasting plasma glucose, again, superior in the gastric bypass group compared to intense medical therapy group. And just briefly, here are the secondary endpoints in terms of glycemic control, lipids, blood pressure, and body weight. And primarily, most of the benefit was with glycemic control and, of course, major changes in overall body weight favoring the surgical therapy. Now, one important point, and this slide's a bit busy, but this does review the adverse events. Now, this, keep in mind, was a fairly small study, so 1 or 2 adverse events will really stick out, and that's exactly what happened. In this study, look at this very first complication. There were 2 anastomotic leaks, giving a leak rate overall of 3%, which is quite a bit higher than what you see in most studies. And unfortunately, one patient in this group really had a very serious outcome from a jejunojejunostomy leak that resulted in sepsis, actually anoxic brain injury, amputation, and many other complications, unfortunately. And this is something we rarely see. I'll also point out that there were some unusual complications in the medical group. There was a case of pancreatitis. There was duodenitis. There was polynephritis, bronchitis. There was a suicide attempt. And there were 2 cases of pancreatic cancer in the non-surgical group. Overall, there were 15 major events in the medical group and 22 in the surgical group. Okay? So, conclusion of this study, mild to moderately obese patients with type 2 diabetes will have a superior benefit after surgery compared to medical therapy in terms of achieving the composite goal. However, this is not without some degree of risk, as previously noted. Now, in conclusion, we now have 3 randomized trials that involve patients with a BMI between 30 and 35. We have another randomized trial above 35, which is quite consistent with these other randomized trials, and they all show surgery to be effective in this BMI range group. Not only does it improve glycemic control, it lowers cardiovascular risk factors. So I think this really does bring us into this new era where we can strongly support or advocate surgery for patients with BMI less than 35 with significant comorbidity, and perhaps diabetes would probably be, at least today, the best or most soundly supported comorbidity in this particular BMI group. So I'm going to stop there, and let's see what Dr. Needleman has to say about these arguments.
Brad, we'll turn it over to you. Welcome to the program. Good morning, and go ahead and start your talk whenever you're ready. Thanks.
Invitation to start this event today. It's a lot of data and slides for 6 o'clock in the morning, but let's talk about BMI, how low you can go. Obviously, I'm going to present the con data. And as a bariatric surgeon like you all, I certainly accept the fact that obesity is a considerable threat to our health and well-being of people all over the world. Without treatment, it can lead to other serious and life-shortening comorbidities. Current medical therapies have really not been adequate in providing significant and durable weight loss in these patients, especially the morbidly obese. And surgery is currently the most consistently effective treatment. I won't contest any of these facts today. As bariatric surgeons, we certainly see the great benefits of the operations. We know effective. We know how they do for the comorbidities involved with obesity, help patients live longer. As a result, we want to offer these to a broader population. And let's face it, it would be really nice to do these operations on those maybe a little less challenging. But I think really the main reasons that I'm going to discuss today why we shouldn't lower the BMI is really, frankly, and it comes down to the fact that there really isn't just enough good scientific evidence yet. And I'll go through some of that a little bit with you as well. By using BMI as criteria, I think it's wrong as we perpetuate the myth that this is actually an accurate measurement of obesity and should continue to be used. As we're changing our image from weight loss surgeons to metabolic surgeons, we need to focus more on the comorbidities to drive indications and not necessarily, BMI as an indicator. Also when we're looking at these low BMI patients, the amount of weight loss that we need to see to show some of these improvements may not be enough to warrant some of these larger surgical interventions that we offer patients as well. I think part of the problem with lowering the BMI too is the public and medical profession's perception of bariatric surgery, while it's improving, is still pretty mixed. And when we lower the BMI criteria too low to what the public and medical community may not perceive as not that fat yet, may hurt our image and credibility. And even with the current recommendations, we're really only helping a very, very small fraction of those who are indicated right now. So what's evidence-based medicine? Obviously, we all want to practice evidence-based medicine. These are the buzzwords these days. Hospital committees devoted to this. The translation of uncertainty to an answerable question that includes critical questioning, levels of evidence, the best available evidence, praising for internal validity, application of results in practice, and evaluation of our performance. So when we look at the data, are we really answering these questions? Is a BMI less than 35, doing surgery on that, really evidence-based medicine? The ASMBS obviously had a position statement already on the bariatric surgery in class 1 obesity, and here are its 4 recommendations. Obesity is a well-defined disease and should be recognized as deserving treatment. Current non-surgical options are generally not effective in achieving substantial and durable weight reduction. And for patients who do not achieve substantial and durable weight loss, bariatric surgery should be a valuable option for suitable individuals, although it doesn't really define what suitable individuals are. And there is no current justification on the grounds of clinical effectiveness, cost-effectiveness, ethics, equity in this group be excluded. And I would counter that there's no evidence to say that they should be included at this point. And banding, bypass, and sleeves have been shown in randomized controlled trials to be well tolerated and effective in the short and medium term. So let's look at those studies a little bit more briefly that what Phil described. There were 4 randomized trials, controlled trials, which is really the level 1 evidence we're going to look for to show that we can offer these patients offer this to patients with a BMI less than 35. If you really break them down, there's O'Brien's study in 2006, 80 patients with with BMIs up to 40, randomized from one to the other group. I couldn't tell exactly in that study how many actually had a BMI less than 35, but assuming that 40 patients had lap bands and 40 had medical treatment. Dixon studies in 2008, 60 patients were randomized, but only 13 of those 30 patients that were randomized to lap bands had a BMI of less than 35. Lee's study was a prospective randomized trial, 30 sleeves, 30 bypasses. All of those patients had a BMI of less than 35. But this study took place in Taiwan, and I'll explain why those differences may not be applicable to us here in the United States in a few minutes. Phil Stampede, great study, 150 patients, 50 sleeves, 50 gastric bypass patients. But really, in those studies, only 18 of those patients who had sleeves had a BMI of less than 35, and only 14 patients had a BMI of less than 35. 14 patients who had gastric bypass had a BMI of less than 35. But when you really break it down, only 32 patients had weight loss surgery with a BMI of less than 35 in the United States, and the remainder of them were either lap band patients or international patients that may have different criteria altogether than what we see here in the United States. So really in randomized controlled trials in the U.S. right now, except for I apologize, I didn't have the JAMA article available just yet, but in the consensus statement, it was really based on 32 patients in the United States. And really, what are we talking about? When you look at all of those observational and retrospective studies, typically what we'll see is a drop of BMI of anywhere from 5 to 7. And a drop of BMI from 25 to 30 is really only 30 pounds. So when we think about gastric bypass, duodenal switch, BPDs, sleeves, are we comfortable recommending these operations right now with the data available to achieve a 30-pound weight loss? Really, when I break that down, is that really consistent with what we want to provide with our patients right now? And really, there's plenty of studies out there that our medical colleagues look at that say that you only really need to lose 5 to 10% of your current weight. A person is 5'8" with a BMI of 30, that's about 175 pounds. So we're talking about, a 17-pound weight loss over 6 months that has been shown to do lots of good things for these patients: lower their blood pressure, lower their body weight, reduce LDLs, cholesterol, glucose tolerance. And then depending on where you store this excess weight, not necessarily based on BMI, there can be dramatic health improvements for those with as little as 2% weight loss. And then what is BMI? For those of you that don't, I didn't know this until I looked this over. Quetelet was a mathematician, not a scientist. When he looked at BMI, he was trying to allocate government resources and using a formula to determine what portions of the population were obese. There's no scientific validity behind squaring a person's height. The only reason he did that was so the formula would actually fit the data. And it makes no allowances for bone, muscle, and fat content. So if we're to say we're going to lower BMI and use BMI as a justification, we all know that BMI is worthless and shouldn't be used, and we should look at other things for that as well. I think the point I really want to make, and this actually might even help Phil make some of his arguments as well, is that obesity is not created equal. The United States is a little bit different because we have a very uniquely heterogeneous population with lots of different ethnic backgrounds and ages and sex. And when we apply this, we don't take that into consideration when we look at BMI alone. Several groups have begun to set lower cutoff points for BMIs and abdominal obesity metrics among Asians. China, Japan define overweight as a BMI of 24 or higher, and obesity is a BMI of 28 or higher. In India, that's even lower, BMI of 23 and 27. And the International Diabetes Federation is a little bit ahead of us as well, because it includes ethnic-specific criteria for the definition of abdominal obesity. And South Asians in particular have actually high levels of body fat and are more prone to developing abdominal obesity, which may account for their very high risk of type 2 diabetes and cardiovascular disease. And some blacks have been found to have lower body fat and higher lean muscle mass than whites at the same BMI. And therefore, at the same BMI, it may not be lower risk of obesity-related diseases, maybe at lower risk, for obesity-related diseases. And therefore, by painting, BMI with a broad stroke for individuals, we may be performing operations on those that may not need it and missing out on those that do. I think when we talk about lowering BMI as well, we need to take into account the public perception. We haven't really yet done our jobs in winning the hearts and minds of our medical patients and society. If they don't believe yet that we offer their morbidly obese patients the best chance for durable weight loss and comorbidity resolution, how will they respond as we as a society try to get them to refer patients with a BMI less than 35, who they're going to be much more skeptical about what we offer. Currently, there are 8 million Americans with a BMI of greater than 40 and 23 million with a BMI of over 35. At the most, maybe we perform 260,000 operations in a year. That number is going down, and maybe, 160 or 170,000 operations this year? So if we're only really reaching 8 out of every 1,000 possible patients right now that have a really very clear and obvious benefit from the surgery that we do, what impact are we going to make on a potentially more risk-averse subset offering the same operations that we offer right now? And many of us are continuing to lobby government and private insurers to cover or expand coverage just to reach the current NIH guidelines. Here in Ohio, we still don't have great Medicaid coverage, and their cutoff for BMI is 50 and on insulin. And as a result, I think if we try to lower those guidelines, we may be wasting resources we could use elsewhere right now. The economic impact, I think, is important and becomes important. Wiener's study that was recently in JAMA, we all know it. My fellow Dr. Funk wrote a really great article, really great letter, actually kind of tearing apart this study that I signed and put my name to. But I'll still read it. Bariatric surgery does not reduce overall healthcare costs in the long term. Also, there is no evidence that any one type of surgery is more likely to reduce long-term healthcare costs. So to assess the value of bariatric surgery, future studies should focus on potential benefits rather than cost savings. But I really think that if we're going to promote bariatric surgery in this lower BMI, greater population, we really need to show also the economic impact that we're making. And studies like this haven't helped us in making that a very strong argument. Look at Shaquille O'Neal. The public perception, here's a guy with a BMI of 32. When a reporter told him he was obese, his response was, you stick to that. Stick to top 50, 3 rings, a lot of money, 2 mansions. But now if we tell Shaquille he needs surgery too, he may rip my head off. So what makes sense? I think instead of just lowering BMI as a criteria and looking at that as well, I don't think it's sufficient enough to serve as an indication for surgery. When I look at this and I started thinking about patients, what needs to be considered, if we say, okay, a BMI of 32 with maybe this comorbidity, we're not taking into account the age of the individual, their gender, their waist circumference, their body composition, adipose distribution, and their comorbidities. I think we need to really look at all of those things and to really understand these before we can offer this to our patients. We really don't yet have good understandings of the causes and risks of each level of obesity related to those things that I mentioned before. Are we going to offer the same operation to a 68-year-old woman with a BMI of 33 with hypertension, diabetes, high cholesterol, versus a 28-year-old former OSU tight end, who has bad arthritis in his back, and offer them both the same operations? Doesn't necessarily make sense. And if you take into account their genotype and ethnic background, I think we're not quite there yet in knowing which operation to offer which individual. I don't know if it's the answer to class 1 obesity, one of our current operations, or is it one we aren't doing yet? Ideally, if we're going to offer and change the public perception, we really need to offer them the least invasive operation, the lowest risk. Think about how tolerable people are going to be with a BMI of 32, showing those sleeve leaks, take backs for bleeding, marginal ulcers, thinks about those complications that we typically see and what their risk tolerance is versus somebody with a BMI of 70 or 60 or 50 or 40, where we know clearly what their long-term outcomes are going to be without the operation. So my conclusion is there simply just isn't enough evidence to recommend bariatric surgery for individuals with a BMI less than 35. BMI alone is just not an accurate indicator of obesity. Modest weight loss is achievable and enough in this group, maybe. We have not yet done enough to understand obesity, its causes and treatments, and we as a society have tried hard to change our public perception to metabolic surgeons. We need to just throw BMI out altogether and look at comorbidities and different ages and ethnic groups to make our determination what we should offer. And since we're only offering it to a very small fraction of our 23 million Americans that may qualify now, we really need to solve that problem first before we expand our current guidelines. Thank you.
Great, thanks, Brad. So we're going to have a couple minutes each to rebut. I'll start with Phil here, and then we'll open the floor up for discussion after these short rebuttals. So Phil, Brad makes the case that there's really not very substantial numbers to justify this as a standard of care type of procedure for these patients, and he also argues that BMI criteria is really making a false argument here. So how do you respond to those?
Well, I think it's really easy. He's wrong. He's absolutely wrong. Remember, what the argument here is not that surgery should be used for all patients with BMI less than 35, but clearly there are some patients that can dramatically benefit that have zero access currently. What I'm saying is that for the appropriate patient, how can we deny a proven therapy? We all know examples of patients, for example, with poorly controlled diabetes on optimal medical therapy who have A1Cs in the 8 or 9% range and are heading toward major diabetic complications. And we know that with surgical intervention, they can have a substantial reduction in cardiovascular risk factors. And add to the SOS data, we can predict that we will reduce dramatically their long-term mortality and cardiovascular risk. Now, Brad says there's not enough data. Okay, 4 randomized controlled trials all show the same thing in these lower BMI patients. It doesn't matter if they're American patients or others or in Taiwan or in Australia, they're all showing the same thing. Brad, how many do you want? Do you want 5 randomized controlled trials? Do you want 10? Do you want 100? How many do you need? And add to that the mounds and mounds of observational studies that all say the same thing. In fact, there's no study published that does not show a substantial benefit of surgery compared to a non-surgical approach. And on top of that, there is a lot of consensus now among other organizations. The FDA. The FDA does not regulate procedures, but it does regulate devices. And it says that gastric banding is appropriate in patients with a BMI of 30 to 35. International Diabetes Federation, look at bullet number 3. Patients with a BMI of 30 to 35 with diabetes, not well controlled with medical therapy, should have access to surgery. Our own ASMBS, Brad used this position statement, which the moderator here, Dr. Brethauer, actually wrote. And look at point number 4. They're basically advocating surgery as appropriate in some patients with BMI 30 to 35. This is our own society. Look at this, Blue Cross Blue Shield Tech Assessment. This is the largest insurance provider in North America. And they have a very strong statement suggesting that, and they only point out gastric bypass, but I'm sure the others will follow banding and sleeve soon, but gastric bypass is appropriate in patients with a BMI less than 35. It meets their stringent tech criteria. And a recent ACE, which is the American Association for Clinical Endocrinology, the Obesity Society, ASMBS guidelines for perioperative management of the surgical patient, points out that patients with BMI less than 35 may achieve substantial benefit from surgery in terms of weight loss, diabetes remission, and cardiovascular risk reduction. And then finally, I think we're beginning to see insurance companies actually modify their coverage policy. Here's an example our own Cleveland Clinic employee plan has lowered the BMI to 30 in patients with diabetes who are not well controlled with medical therapy. So I think the acceptance of surgical intervention, not based on BMI alone, but based on comorbidity, is beginning to really take hold here, and we're beginning to see both patients' demand, and we're seeing insurance policies change to accommodate this new evidence. So there you go, Brad.
All right, Brad, you have a couple minutes to respond to that, and then we'll go over to the audience.
Hey, Phil, could you see me shaking my head in haughty derision? No?
No, I can't see you at all.
Yeah, it's too bad. Yeah, I mean, I totally agree with you, except on one point, that it's you that wrong. Because obviously we need to include more than, I mean, 4 randomized controlled trials are fine, but I would ask you several questions since half of those studies were on lap bands. Does the Cleveland Clinic still perform lap band surgery? You don't have to answer these questions. Are they still performing that operation or not? 2, the second question I would ask you is, do we really believe that somebody with class 1 obesity and diabetes is the same as somebody with class 2, 3, morbidly obese, BMI of 80 and diabetes, if that's really the same disease process? And the second thing I would say is that the studies that you show, the observational cohort studies, are really very, very short term. And we're looking at, 1 year to 2 year follow-up in the vast majority of studies. Rarely looking over this do I see anything that's more than 5 years in follow-up. The Swedish obesity studies that you bring up as well, while it shows good long-term results, those are certainly in much higher BMI patients. Some of the observational and retrospective studies, including Scopanera's study in 2011, which was a prospective studies of biliopancreatic diversions, which is probably the best of the operations that show remission of diabetes, actually showed that there were much higher remission rates in those individuals with higher BMIs than those with low BMIs. So I think what we really take from this is perhaps a diabetic with a BMI of 31 and 32 is not the same as a diabetic with a BMI of 42 or 52 or 62. And therefore, to offer them the same operations, thinking we're going to get the same results, just because we do really well in BMIs of 45, we're going to do the same with BMIs of 25 and 35, I think is inaccurate. Looking at some of the DJB studies, certainly from China, shows that those operations themselves don't necessarily make as big of a difference as some of the other operations that we do, like gastric bypass. In addition, there is some weight regain in these patients long term, after gastric bypass. When we look at an 80% excess weight loss in an individual that's only 40 pounds overweight, we're talking about 30, 35 pounds. If those patients then gain back 10 or 15 pounds over the next 5 or 10 years, they're back to 50% excess weight loss. So are we really ready to offer, these patients these large operations, put them at risk for some of the, long-term permanent changes in their GI tract without really knowing what's going to happen 5, 10, 20 years out? Is it really fair to offer a gastric bypass patient to someone with a BMI of 32 on type 2 diabetes without really knowing if their diabetes is going to be better just for 2 years or 5 years or 10 years? I think if we tell them all we know is that your diabetes is going to improve, 80% of the time, which isn't even really what the retrospective and observational studies show. In many of those studies, there's only a 50% remission rate, and some only a 25% remission rate with improvement in 50%. If we tell someone with a BMI of 32, all we really know is that at 2 years, half of you, I'll even take it and say 80% of you will have remission of disease, but we don't know what's going to happen 6, 7, 8 years, 10 years, 14 years down the road. Is someone going to be willing to want to have that operation for a 30-pound weight loss and only known for 2 years of resolution? I think it's a little too much to ask for them right now until we really have more data, especially long-term data, specifically in that class of diabetes, because we just don't understand it all that well yet.
Great, Brett. Thanks so much. Those are great comments, and I'm sure you guys could talk all day about this. But let's go out to our one of our sites. If we could go to Mount Sinai Medical Center. I have a specific question. It certainly would welcome your general thoughts on the topic, but let's accept the premise that it's a good idea to do surgery on these diabetic patients with lower BMIs. What operations should we be doing? Should we? It's all about risk benefit. Should we be looking at an operation with less risk, but perhaps fewer metabolic effects, or should we go for an operation that really has what we know to be the most powerful metabolic effects with a known higher risk? I see Dan and I don't know if Barry's there, but any comments there, Dan?
Unfortunately, Barry is out of town at a research meeting. But first of all, I'd like to congratulate both Phil and Brad. But I'd like to congratulate Phil maybe a little bit more because I think his arguments were a bit more coherent there. But before you start talking about the details of which surgery to do, I think it's important to go back in history and ask why we're having this argument in the first place. I think it's important for us to remember that the BMI cutoff of 35 is a very arbitrary cutoff, which was made by a consensus conference over 20 years ago now. I think that if you saw the kinds of differences which we're seeing between surgery and medical treatment in almost any other field, you'd probably have to stop your randomized controlled trial halfway through because it would be unethical to deny surgery to the other patients. So I think that it's very important to make sure that we're kind of treating metabolic disease and obesity the same as we're treating other diseases. So we hear a lot of how we may only be helping 20% or 40% of our population. If you were talking about those numbers in a cancer population, those would be incredible, and there would be people breaking a path to your door to try and get that surgical therapy. In fairness to Dr. Needleman, I think the one concern that we haven't really addressed is the long-term durability, and we don't know really what the results are going to be 10 years out, 15 years out, 20 years out. So I think there are still some unanswered questions, but I think we really should be staring the data in the face and saying, look, we got 4 randomized controlled trials supporting surgery. At a certain point, you have to stop asking for more.
Great, Dan. Thanks. We're going to appreciate your comments. Those are great. Just a quick response. Do you think the gastric bypass is the best operation for this group of patients, or do you have an opinion on that?
I do think gastric bypass is the best operation. It's been around for a long time. We're well educated as to how to do the operation, how to do it safely, quickly, effectively, and how to treat the complications. That being said, I find in my own practice a large segment of patients who, for whatever reason, are not willing to accept that operation. They don't like the idea of the malabsorption and the reconnection of their intestines, and they're more comfortable, or they're only willing to accept a sleeve. So I think sleeve is also an excellent operation with not quite as good numbers. So I would generally recommend bypass first, but I think sleeve is certainly an excellent alternative.
Great. Real quick, Phil, I have a quick question, and then we're going to go to VCU, and then we'll probably have to wrap up for time. But Phil, the data we presented with the Stampede trial was 1-year data. We now have some 2- and 3-year data. How is the sleeve, in reference to Dan's comment, how is the sleeve shaping up at 2 and 3 years?
Yeah. Well, you can see a hint even in the 1-year data, although there was no statistical difference in the remission rates between the sleeve and the bypass. There was a higher percentage of patients, 42% versus about 35%, who actually achieved that. And we haven't published this data yet, but as we go out further, we're seeing the efficacy clearly separate between the bypass and the sleeve, favoring the bypass procedure.
So that may raise some more questions in terms of the durability issues that we've raised, and trying to find the right operation. Certainly, I think that's remains an unanswered question in this particular population. Okay, so we have a question from Virginia Commonwealth Medical Center. If we can go to that site. Good morning.
As Phil knows, I always have an opinion about everything. This time I agree with Phil. I think patients with uncontrolled diabetes of BMI between 30 and 35 should be included. But the real problem is insurance denials. Now, it's good that Phil forced his own insurance company to cover, but we don't have that power with Anthem, Blue Cross, Blue Shield, and the other carriers. So I think, and I'm not criticizing Phil's study, I thought it was an excellent study, but what we really need is a huge multi-center comparison trial, gastric bypass being the best diabetes operation versus medical treatment. and Phil should be the PI, and we here at VCU would like to be co-investigators.
Well, I certainly support that. And John, last week there was an NIH workshop on this particular topic, and they raised that issue. You know, these are very expensive studies. We're talking about tens of millions of dollars. They're difficult to do. Recruitment is difficult. But we really do need to answer this question. We're spending, we spend about $2 or $3 billion per year on gastric or bariatric procedures, and you think that we could spend a few, 20, 30 million on a definitive trial that shows the efficacy and safety. I agree.
Great. Well, thanks for everybody's comments. We're about out of time here, so I'll wrap things up. But I appreciate Brad giving his comments and insight. Phil, thank you very much for a great presentation as well, and for all the folks that participated. We'll take the month of July off as we're all getting our new residents and fellows settled in, and we'll resume our program August 2nd with another Innovations in Surgery, a presentation of abdominal wall reconstruction and abdominal wall function by Dr. Igor Belyansky from Anne Arundel Medical Center, moderated by Adrian Park at the same center. So I wish everybody a happy July and a good summer, and we'll see you again back in August. Take care.